Today we will, yesterday we started with a global perspective from WHO, from the research community. We went on with some very extensive country presentations. We went then on with a big panel on access to insulin, and we had the breakout sessions to end the day. Today we will start out with the morning panel about practitioners' perspectives, and in the afternoon we will have a panel around international partnerships before we end with a panel of people with lived experience. For the first panel today, we have entitled it Type 1 Diabetes Care in Low and Income Settings, Key Challenges and Potential Solutions, Practitioners' Perspectives. And to moderate this panel, I would like to invite the Honorary Secretary General of the Tanzania Diabetes Association, Dr. Kaushik Ramaya, please. And for the first panel, we would like to invite Dr. Babacar Niang from the Senegalese Diabetes Association, from the Juvenile Diabetes Association in Peru, Segundo Seclen, please, and from Gandhi Medical College and Hospital in India, Dr. Vijay Reddy, and finally from Ghana, Kolebu Teaching Hospital, Dr. Lanti, please. And the word is yours, Kaushik. Thank you. Slide.
Yeah, good morning, everyone, and we are going to have interesting two panels this morning. As Bent mentioned, yesterday we started discussing about the global framework. We started looking at different programs, different national initiatives, but whatever you do, it crystallizes to what is actually being provided to the person with type 1 diabetes, and it is that last mile whereby you provide the care and the treatment, but at the same time provide all the commodities which are required. And the main objective of these two panels we are going to have this morning is basically learn about the health system responses within the different environment, different countries, whether it is low middle income country, whether it is high income countries, and how do we go through the complete patient pathway, right from the time of diagnosis, being managed at the health center or health facility, identifying the complications, managing this individual, retaining him care, and then making sure that the control is good. We are also going to look at what are the different ecosystems which are required to ensure that you provide a good quality of care. So within our first panel, we have got Dr. Babacar from Senegal, we have got Dr. Seklan from Juvenile Diabetes Association of Peru, and then we have Dr. Vijay Reddy from India, and then we have Dr. Roberta from Ghana. So the format is going to be that they are going to either they have a slide or they have an oral presentation. They've been given the scope, and they'll be talking for about 5 minutes to 6 minutes. And then after each one of them has finished, then we'll be having some questions, discussions, and then we'll open it to the floor. So, Dr. Babacar, you are welcome.
Thank you so much. I would like to thank the organizer to allow me to share our point of view in terms of challenge and potential solution of managing diabetes in children. I'm here as a practitioner and as a member of Senegalese Diabetes Association, which is an association has been created in 1967 and is recognized as a public utility by presidential decree, and it is important for advocacy, awareness, and support for patients with diabetes. My next slide, I will talk about the current situation of type 1 diabetes management, key challenge and potential solution. In Africa, I think we share the same problematic. We have the lowest report data in type 1 diabetes. We have few, sometimes no pediatric endocrinologists. The life expectancy for children with type 1 diabetes is short, and we have more than 80% of non-diagnosed type 1 diabetes. And our national health is too weak to take care of this case. And in Senegal, I think the two programs will improve the training and management of type 1 diabetes are CDIC. I think since 2016, we have CDIC, and that improve really the management of diabetes. In terms of training, we have the pediatric endocrinologists in Africa, we call PEDAF. We are training many people in Africa in pediatric endocrinologists. And the solution was the partnership between public and private, and CDIC is an example. In CDIC, since 2017, we have now more than 1,600 children with taking care in CDIC, and every year we have more than 200 children. And we established more than 21 clinics in all Senegal, and all the region have now at least one center of diabetes taking care of children. And the key impacts are on children. Now with the diabetes education, we ensure the more compliance for children. We have reduced the patient developing daycare at the time of diagnosis, moving from 86% to 68% in 2022. We decreased mortality from 6.7 to 2.6, and now the main cause of mortality are not diabetes. We notice most of them died at home because of other cause, not only diabetes. The quality of life has been monitored. We improve the quality of life of children. On management, we have now diabetes education with well structured, with some diabetes camp organized every year for children. We train more than 400 healthcare professionals, and we have a protocol of insulin validated in the national level, and we established 21 diabetes clinics. But we have some challenge. We still using human insulin. For more than 2/3 patients, we use human insulin. Chronic complications are not systematically checked for children. We don't have many of them for routine check of retinopathy or nephropathy. And this leads to bad control glycemia. We have the mean HbA1c is around 10%, and less than 30% of children have good control. And we have inequity between rural and urban. Here you have an example. Patient was traveling with bicycle for sometimes for more than 10 kilometers, and stealing insulin storage is bad sometimes, and that leads to bad control of diabetes. We need to break this inequity of management of children, and this lead to chronic complication. We notice some complications here. We publish some case of retinopathy, cataract, bilateral cataracts. We have been operated, and we remove the cataract. We analyze chronic complications. The most important complication was growth retardation. We have in 28%. Microalbuminuria was present in 20%, and retinopathy also. And this chronic complication was being associated by high level of HbA1c. The potential solution, I think that we have at least a macro level in the ministry level. We have national health policy on chronic transmissible disease, communicable disease, yes, like infection, malnutrition. But we don't have national health policy on non-communicable disease like type 1 diabetes. We need to integrate the non-communicable disease on the national health. We also have universal health insurance, but only for children less than 5 years and children with communicable disease like malaria, tuberculosis. We need to integrate this into the universal health coverage. And also we have an epidemic monitoring system for non-communicable disease. We have to integrate also the type 1 in the registry, and this to develop the sustainable solution for management of type 1 diabetes. At the meso level, I think that CDIC is agreed to give from this year the analog we spend. I think it will improve the quality of management. We need also the continuous glucose monitoring. I think it will help to improve. We are still using glucometers with strip, but I think that continuous glucose monitoring will help to improve the quality of life. We have also one emerging problem is transition. Many of children have more than 20 years. We need to move them from pediatric to endocrine adult. It is a very big problem for us. And at micro level, we have to continue to promote self-management by association. Association is important for awareness, for advocacy, to management of diabetes. We have many actions we are doing, training, camps, diabetes camp we are doing every year. We are doing communication in the local media, and we are working with the ministry for sustainability. We are working to have some memorandum understanding to sustainability for the management of type 1. Thank you for your attention.
Thank you very much. If you have comments or questions, please keep a note. After all the speakers, we'll keep an open floor. Yeah. So can we hear from Peru now?
Good morning, ladies and gentlemen. Thank you very much for the invitation in representation of the Latin American people. I'm endocrinology. I'm president of the Diabetes Juvenil Foundation in Peru, but president of the Latin American Association of Diabetes. My exposition is the experience about the working in the health public system from Peru 40 years, and now as the medical director of the Changing Diabetes in Children in Peru. This picture is the hills, the lands where they live, the people in the program development. The program is in health center of Lima, Peru, in the primary level care. The program create diabetes modulo of type 1 diabetes attention in the health center in Peru. This picture is an inauguration of module in in the center health from medical level primary. The program have a program assistential and educative from young and children with type 1 diabetes. Actually, we have 8 centers of attention of this disease, and near 500 of young and children with diabetes type 1. So the experience in this work identify the necessity of the capacitation of the team of salud and level primary care. And this is our experience. The main change for a diagnostic and managing type 1 diabetes in Peru is first, the health professionals do not receive sufficient training for diagnostic and management of people with type 1 diabetes. Some professionals, for example, don't know that exists the type 1 diabetes. It's a very great problem. Second, the insulin and devices, such as glucometers, are not available to all patients. The public system don't give the glucometers and insulin free. The basic technique for the diagnosis and evaluation of type 1 diabetes do not exist at the primary care level. The primary care level after the pandemic is a important reforce, but in Peru no existed this section. For the type 1 diabetes clinical guide, do not is followed in public health centers, and patients and their family do not receive the necessary education about their disease. This 5 problem is the main changes that identify in this program in general in the primary care level in Peru. This slide, for example, can you see the basic technique for diabetes available in primary care in the Latin region, many countries. For example, in Peru, only the glycemia, no, for example, glycosylated hemoglobin, no ophthalmoscopy, no center for diagnostics of neuropathia diabetic, and no strict glucosuria and ketonuria in relation with another countries of the Latin America. But the critical problem in our system of health is the inequality in access to insulin. This is a study on the Crónicas group in Peru in 6 regions, which demonstrates that the regular human insulin is unavailable in 37% of public pharmacies, and isofan human insulin is unavailable in 32% of public pharmacies in Peru. Insulin analog, evidently, are not available in general in public system. How the resource limitation impact the quality of care of patients with type 1 diabetes? First, there are higher incidence of morbidity and mortality, general infections, chronic complications, and many hospitalizations in patients with type 1 diabetes. The mortality is subdiagnostic. I know I have many deaths in this group. The glycemic control is inadequate, leading to a high occurrence of acute complications such as ketoacidosis and hypoglycemia. When our patient go to the hospital, can last 2 or 3 months, which in turn delay the start or no insulin prescription. Public insurance, that is inexplicable, only cover human insulin treatment for patients under 18 years old only. Limited access to insulin in some hospitals forces patients to purchase it from the private market, adversely affecting their financial well-being. The salary in Peru is approximately $400 and then 20% spent in the purchase of insulin. What strategy the clinical use to overcome barriers? First, is necessary training for non-specialist physicians and healthcare staff in the management of type 1 diabetes. It's the first strategy. The second, the telemedicine for consultation with specialists, educational program for patients and the families, provision of insulin and blood glucose monitoring device. This is the many programs give the insulin and blood glucose, for example, changing diabetes in children, and advocacy for type 1 diabetes at both public and private level is very necessary. For example, the general law of diabetes and the regulation and the guide for type 1 diabetes is in association with the patient group that input the promulgation of this tool. How do clinics perceive the role of patient education? Patient and family education is crucial for the proper management of the disease. But the support of a multidisciplinary team is necessary for patient management, including specialists or physicians trained in insulin therapy, and nutritional, a psychologist, an educator, and a dentist. What improvement or change do clinics believe are necessary to some type 1 diabetes? First, public policies should be established through legislation or legal framework to create type 1 diabetes care program in primary care facilities in hospitals. Second, a to-type clinical practice guide is essential for the management of type 1 diabetes. A national registry to track the number of patients with type 1 diabetes is necessary because the Ministry of Health and the Ministry of Economy should allocate a specific budget for the purchase of insulin, blood glucose measurement device, and test kits. Training program for health professionals and educational initiatives for patients, family members, and the community are critical. And this last is very important. Direct negotiation between pharmaceutical company and the government should be purchased to lower the price of another insulin. Finally, key message: the care of patients with type 1 diabetes is achievable at the primary health level with a well-trained multidisciplinary team in coordination with the hospital system. Second, in an environment with a short time of specialists, we need to dispel the myth regarding the exclusivity of pediatric endocrinologists or endocrinologists in managing type 1 diabetes. Three, health policies should strengthen primary care by implementing basic techniques for diagnostics and providing analog insulin and blood glucose control device. Diabetes education program for patients and family members should be integrated into the Ministry of Health promotion activities. Advocate on the participation of the patient community is crucial. And finally, urgent negotiation between the pharmaceutical industry and government are needed to establish fair pricing for another insulin. Thank you very much.
Thank you very much for that comprehensive presentation. Can you have Dr. Reddy from India, please? Yeah.
Good morning, everybody. Thank you, Dr. Kaushik. I should thank Dr. Band, especially from WDF, in inviting me. I feel honored. And I do not have slides, but on the same questions, I'll try to, answer a few of the things, because I'm a clinician practicing, so I cannot give any national data. So as you know, the managing of type 2 diabetes, particularly in low socioeconomic settings like in India, with a huge population, has a unique challenges because of the socio-economic disparities and also due to healthcare limitations. So I'd like to just, again, rewind what earlier people have talked, but very fast. We got challenges in the clinicians, including diagnosing and also managing. Some of them are, this is through my experience I'm talking about, lack of awareness among the primary healthcare providers regarding the knowledge of diabetes, especially because they were never stressed in their undergraduate curriculum regarding the NCD management, diabetes, and especially type 1 diabetes. Secondly, lack of accessibility to many of the people in the periphery to the healthcare professionals is the biggest thing. Third is lack of infrastructure for screening of the stage 3 of the type 1 diabetes, or even in the secondary and tertiary centers to differentiate between what is the type of diabetes in young individuals. There are misconceptions among the people and also among the primary health providers that the diabetes is not very common at young age, it is only common in the late. So most of us patients present very late with hyperglycemia and decay. Then the fifth point is preferences for the other cheaper systems. And only when they have problems, are not diagnosed, not managed properly, they'll come to the allopathic management, and again late in the course of the disease. Absence of national screening guidelines. This is too premature to talk about the guidelines, but what I see, because over the years we are looking into now, yesterday also people were telling that in countries like Rwanda and Uganda, late in the course of the disease like cerebral malaria, encephalitis, they are later diagnosed. Like that, many of the cases we miss in our clinical practice. These were never stressed. Just simple loss of weight. Every time a differential diagnosis is always made for infectious disease, that's tuberculosis. And the screening for the diabetes is never done. At the periphery, for the simple loss of it, they'll think of thyrotoxicosis, other things, but never think of diabetes because it's not very common at that age. Or in the stage, if some fever, maybe it's an infection, cerebral malaria is the usual thing, encephalitis is the usual thing. So it's often missed. So at least some of these cases, we should take a chance for opportunistic screening. Any individual, any child less than 25 years coming to the primary health center should be screened with a simple screening test. Then for treatment, we have got limited access to the insulins, analogs, needles, glucometers, strips, CGMs, cold chain monitoring, even regarding the dietary education, because predominantly our diet is a carbohydrate diet, and there the problem of getting a quality of food, quality diet, which includes the, like millets, nuts, legumes, and all these things, is not a possibility for everybody. So these are some of the problems which we have in managing the diabetes: availability of insulin, availability of the monitoring things, and then the dietary advice is also the availability of the diets and instructions to what diet to be taken. These are some of the problems which we have. And we also got, because poor emergency response, because we do not have at the periphery or the district level to manage people with type 1 diabetes. Or simple hypoglycemia sometimes itself we cannot manage. And availability of glucagon, these things are also not available. And there are also some indirect problems in the form of social stigma. Some people, especially in the rural areas, who are diagnosed to have diabetes, in children, is the biggest marital challenges to them. Nobody want to reveal that I got diabetes. Especially in the female, it's very difficult for their marriage. So they never come up openly into the society. They need a lot of motivation and education. A lot of bullying will be there in the schools and other things though. So, a lot of emotional burden leads to a lot of psychological problems. This will also, can lead to delayed in the diagnosis and also mismanagement. And lastly, because of the barriers of the education itself to the patient. This is again because low illiteracy rate. We find very difficult to educate our patients regarding insulins, what diets to be taken. So it's not only that low illiteracy, every 200 kilometers you go, there's a language disparity. And absence of educational material in the local areas. So these are all contributing for the diagnosing and management of type 1 diabetes in our country. And next, so I'll just try to also touch upon, so what are if at all we have these resource limitation, what is the impact and quality of care of our patients we have? As you know that lack of availability of insulins, proper insulins, continuous supply of insulins, glucometers and all those things can definitely lead to the poor glycemic control. And with the frequent use of old insulins, especially those children with a long duration of diabetes, there can be problems of hypoglycemia and early onset of complications. And this again not seen. And because of the lack of resources, people skip taking doses of insulins. Dose of insulin or skip insulins, and then they'll end up with the complications, hyperglycemia, or because of lack of maintenance of the cold chain. So all these things are leading to problems in the management and hyperglycemia and early onset of the complications. And thus overall expectancy of the life also is decreased. So for which I'll come to it later. And the lack of availability of specialist HCPs with investigative facilities across. I'm not telling that it's a very fragmented availability in the remote areas. Investigative facilities, even in the tertiary centers, to differentiate between what type of diabetes is also important. So this is posing a lot of impact on the control and management, frequent admissions to the hospitals. So what strategies do clinicians use to overcome these barriers? What we are doing is, most of the barriers or the components in the management of diabetes are not there in the hands of a clinician, to tell you frankly. The only arm we have is education. Education regarding how to take insulins, education regarding how to store insulins, education regarding how to maintain in a resource-limited situation to store the insulins, education regarding what are the symptoms of hypoglycemia, when can occur and how to treat with the simple things, education, regarding the diet, even with the poor available, as I told you, the carbohydrate is the predominant diet which I had. So making the preparations, with the same carbohydrate diet for a low glycemic index also can be educated to our patients. So these are some of the things which we are taking care to treat our patients. And the only thing which most of the times we do is take clinical criteria to take or diagnose a type 1 diabetes. Not all the antibody tests or C-peptide levels and other things are not being done. So the problem is again the education. Education at the periphery level, the primary healthcare provider level, people are not aware of the importance of it, or even if they know, busy with their, practice, and, most of the pediatricians and general physicians, they see 100 to 120 patients a day where they cannot concentrate for, on a given patients for 20 to 30 minutes. It's very difficult. So, which is actually a crucial component which empowers the patients and, which improves the self-management and better glucose control. These things are lacking, and which is actually should be very personalized and should be very comprehensive and sustainable, which is lacking. And this is possible only at a tertiary care centers who are educated. So the improvements which I suggest, what we require is to have a proper type 1 registry, not only knowing about the basic demographics, but also certain other variables also can be included in the studies, and you'll be getting the data, and something can be analyzed which through which we can know the disease trends, what are the practice methods going on, how it can be improved, can be informed to the policymakers and also to the clinicians, which can really help in reducing so many things, reducing the acute and chronic complications. So thank you with this.
Thank you very much, Dr. Reddy. So, Dr. Roberta, let's have your views from Ghana.
Good morning, everyone. Yeah. So, whilst I just get ready, if you are sitting next to somebody, I don't want you to speak with them, but I want you to write down what their name is. So if you have a sheet of paper, just the person sitting next to you, write down their name. If there's nobody sitting next to you, maybe find somebody sitting next to you. I believe you don't talk to them. I think that's done. And then after that, I want to give you an easier question. Just look at their face very well and decide which month they were born in. That's question number 2. Look at their face very well. Don't talk to them. Write the month they were born in. And the easiest of all, look at them very well and write the day of the week that they were born in. I thought I'm going to start off my presentation by bringing one of my patients who just came along with him. Let's call him Kofi. So Kofi is about 17 or so. He's his mother's only child. When I first met Kofi, he had been brought in unconscious. Long story short, he had gone to being seen in a number of primary care places, being sent home, given some medication, some fluid therapy, but he wasn't getting well. And the day they eventually landed in our facility, he was unconscious. I'm sure you've heard this story several times. We made a diagnosis of type 1 diabetes, and today he is doing well. So the question I was asked is, what are the challenges that clinicians face in diagnosing type 1 diabetes? And the first challenge is making the diagnosis. Why is there a challenge? Because there's a gap in knowledge. I think you've heard that already. And I've explained that with Kofi's situation. Then most people make a clinical diagnosis. So it is diabetes. But as to diagnosing type 1 and not type 2 or any other form, being able to say that, you are going to need to be able to do autoantibody testing, be able to do C-peptide testing. That is not available, that is not done. But most people are able to make a clinical diagnosis if they don't miss the signs, if they are able to pick up, identify. The other challenge with diagnosis is having to pay out of pocket. So opportunistic screening does not happen. The person comes to the clinic, and whether you do the test or not depends on whether they can pay out of pocket for it or not. And if they can't, then it doesn't happen unless they come in an emergency, and then everybody else is running around. Genetic markers, forget it, that is not available. Making a laboratory diagnosis, and you know that the diagnostic criteria for diabetes is a plasma test, not a capillary test. So first of all, there's lack of knowledge around that. There's lack of availability of the diagnostics, the facilities, places that can do it, and lack of expertise. Assuming that there are no other patient factors, the other challenge that clinicians have in being able to make the diagnosis is the time that the patient presents, the general health seeking attitude. Most people take pride actually in saying that they don't have to go to the hospital. They are very well. And they believe that once they are well, there's nothing wrong. Unfortunately, that is not true. So we end up with a lot of late presentations, people coming when complications have set in. The other problem is, what challenges do clinicians have in managing type 1 diabetes? Fundamental to managing any form of diabetes, whether type 1 or not, is self-management education. That is the fundamental. That is where it starts. So there's a challenge there. We don't have structured self-management education programs. Some of my own research have worked in that, and we are trying to do something about it, but that is not available. So there's a gap there. And then also human resource flux. So you train somebody, they are getting well, knowing how to manage, and then they have to move for whatever reason. We have a lot of that. Organization of care in the facility. So oftentimes chronic conditions are mixed with acute care. You know, you are not going to be able to do individualized education in the midst of other acute conditions. So the organization of the care is a problem. Usually we say that if you're managing somebody with type 1 diabetes, newly diagnosed, you want to be able to do the first injection in the clinic. Why? Shows you that they understand, they can draw their insulin, they can, you are able to, but that means a whole lot. If you are going to be able to do that first injection in that clinic, that insulin must be available where you are. The supplies must be available where you are. You must have a room. You must have a dummy. You must have somebody who is trained to be able to. So there's issues in that. Patient-facing materials. You educate somebody, you expect that you'd be able to give them something to go home with. Our patients tell us, yes, I may not be able to read, I may not be literate, but I live with somebody that can read. But it comes at a cost. We don't have patient-facing material, things they can take away with them. Internet connectivity is a problem. So when you come to using virtual, there's a problem. There's no curriculum. So you want to do a structured self-management education program. We don't have a structured program. We don't have certified educators. So what you get depends on who you see and what they know or what they do not know. Mental health is a major issue, very major issue. So type 1 diabetes and other forms of diabetes are associated with stigma. So it affects mental health, and there's a burden in that. People live in built environments, so physical activity, forget about it. Food seasonality affects cost of food. So all of that goes into managing diabetes. Now, when we come to, aside self-management, we come to medications. You've heard it several times. Stockouts, availability of supplies, availability of insulin, kinds of insulin. What regimen do you have available to you? If you are managing children, you know you want to do basal bolus. But if all you have is premix, that's all you have. And then commitment to medication. So people have said adherence. I like to say commitment. So sometimes the patients are not committed to injection therapy or multiple injections, or committed to being able to do that. And then continuity of care is another challenge. So you come in, today is this practitioner, the next day is this practitioner. That can be challenging. The other question was, how do resource limitations impact on the quality of care of patients with type 1 diabetes in these contexts? Well, if you have a gap in the knowledge, then something else is going to fill that gap. So all sorts of other things fill that gap. We have competition from alternative practitioners. We have competition from religious leaders. So they fill the gap because the knowledge is simply not there. And sometimes you end up perpetuating myths. Even in facilities, healthcare facilities, you hear the wrong thing. So that affects quality of care. Foot exams are not routinely done, eye screening, because there's just so much lack of standardization. What you get really depends on who is taking care of you, rather than a systematic approach, a systems-wide thinking. If we are licensing this person to take care of people with that type 1 diabetes, somebody working on the front line, then this is the minimum they must be able to do. This is a system that works. Unfortunately, we don't have that, and that affects quality. Tests which must be paid out of pocket are not done. So yes, routinely from a quality point of view, you will probably get a blood pressure check, probably get a finger stick test, but are you going to get an UACR test? Are you going to get your eyes checked? Are you going to get a foot exam done? Probably not, because those things come at a cost. And so what happens is that most clinicians are working in the dark. You are working in the dark. The person comes to you maybe once a month or once every 3 months, and they only have that point of care glucose reading. You don't know what their cholesterol is. You have no idea what their kidney function is. You have no idea what their sugars have been over the past month or past 3 months. You are literally working in the dark. And that single reading that you have is probably post 24-hour fast. And it's a fasting. You have no idea what their post meals are. So you are working in the dark. And you are supposed to work and manage these patients. We don't take care of mental health issues, which are very serious. And, just living with type 1 diabetes comes with its own burdens and its own mental health issues. People reuse syringes. There's a lot of data what happens when you reuse your syringe, and the complications associated with that. Sometimes we end up with glucometers which are substandard. There's been some publication, I can't remember the paper now, but they went across and all the glucometer readings were wrong because they were not properly certified or for whatever reason. And hospitals are using home glucometers, not hospital approved meters. So you have no idea. The reading you are saying, is it really 7 or is it actually 10? Or worse still, is it 2? So that's a problem. And because you are working in the dark, it takes long to intensify the therapy. Whereas if you had more data, you may have intensified therapy earlier and saved that person from complications. So what strategies do we use? Well, they say reduce and reuse. That one is for plastics, but that's what's happening in low middle income state. Reduce. So the patients themselves decide that my insulin is going to get finished. Instead of using this appropriate dose, they reduce it or they skip some. And I already talked about reusing single-use needles. And then fill in the gap. What do? We tax shift. But we need to be careful with tax shifting. How much training have you given that person you are tax shifting? And too often, I'm sorry to say, tax shifting becomes tax dumping, which should never be. When you tax shift, you must make sure that quality is not impaired. We try to fill the gap by doing group education. But, so you get educated on foot today because you came in today and the education is on foot. You never hear about eyes because every time you come, it's foot. We try and manage with the group education, but we need to move beyond that to structure self-management education, put people in a class and make sure that they have the life-saving in education. Then we work with partners. Some people have changing diabetes in children, and you've heard from partners what they are doing. We reach out to our NHIS and try and say we need to do better with what we are doing. But of course, try and get the patient to own their care. So you say, oh, okay, is this what it is? Well, maybe instead of buying credits, I will buy glucometer strips. And the patients try to manage with what they have. Role of patient education, all clinicians see that it's a very big need. And they use words like crucial, non-negotiable, important. And some clinicians who have had the benefit from our research of being educated to become certified educators said it has changed their own lives and their own choices. Also instrumental in improving outcomes. So kindly change your papers and let your partner mark so that you see whether you got their name right and got their reply. Thank you so much.
All right, so this was an interesting session. We went from West Africa in Senegal to Ghana in West Africa again, and then we went to India, and then we went to South America in Peru, and we heard all the 4 different experiences. So before I ask them any questions, the floor is open. You want to ask any questions? Okay. So can we start from here, then we come here, and then we round off. All right? How many of you are willing to skip off your coffee session to continue the sessions? Yeah.
Thank you, Kaushik. I just want to thank all the 4 speakers. And this is the session I've been waiting for. Over 20 years, we've been trying to get insulin to children, because they said the lifespan of a child with type 1 diabetes is about 1 year in Africa, the Mozambique data, which we have changed. Now we have thousands of children on insulin, and even, as I saw from your coverage, very high. Isn't it time we concentrate on the major outcomes in these children? That is better control, so that they live a longer life, than see what this man said from Senegal, that they've started developing retinopathy, they're developing neuropathy, but they're on insulin. So aren't we, as physicians, going to concentrate more now on proper quality care, rather than saying 1,000 children have insulin? Thank you.
We'll collect 5 questions, then you'll reply, and then we'll go to the next page. Yes, please? Yeah. We had this lady there.
Thank you, Phoebe from Kenya. What I've been hearing from all the presenters are gaps, and the major gaps are on human resource. And I remember Dr. Segundo sharing that we need to dispel the myth that type 1 diabetes can only be managed by pediatric endocrinologists. But again, we have to balance that with quality of care. So just sharing what we've done in Kenya is we started to build the guidelines for type 1 diabetes in children and adolescents, but we felt it's not enough. So we had to go ahead to develop on-job training materials. And we trained a number of select healthcare workers. But even after training, they said, we need to go to where they are to offer mentorship so that they see what we are doing and also follow up. So at the end of the day, we have to pick out the low-hanging fruits and see what we are able to do as clinicians together with the Ministry of Health, and then of course now involve the partners for more. Thank you.
Thank you. Next question. Yeah. We have 2 on this side. Yes.
Simon Gabic in CDLI in Georgia. I don't know, maybe I came to different contexts, but what I hear during the last 2 days is not fully understandable for me. First of all, I should mention that Georgia is not also a high-income country. We have serious political and economic problems, especially now when the country has serious political crisis. But what I have seen during the last maybe 5-10 years, situation improving very much concerning to type 1 diabetes. I mean, in terms of improving, I'm not talking about insulin, but in terms of CGMs, all children now and adolescents are provided CGMs by the government to supply, also other diabetes supply. I'm talking also about education of doctors, children, parents, and raising awareness of the community. So we have making this progress. So what I don't understand fully, and it concerns not only the panelists, but it concerns also the other presenters, country presenters, which had the presentation yesterday. So what situation that you have in your country do you receive as a granted that you cannot change anything, or there is some slowly but steadily improvement in this situation? Maybe it's improving, but I have not seen it in your presentation. So can you tell more about it, how situation improving, or you have just this problem and nothing can be changed? Thank you.
Thank you for that very relevant question. There was another hand there. Yes, please.
So my question is to the last speakers. In your presentation, you speak on about the reuse of the syringe or syringe. So could you please clear it?
Yeah, so she will mention that.
Yeah.
Okay, next one. Yes. Crispin, yes.
Thank you very much for the presenter. I know from the experience of managing the type 1 diabetes program as well, that it's not only providing insulin and glucose meter, it's more of mourning with those who pass away, with the family, convincing the partner to not leave. It's more human to human connection. So my question is, aren't we forgetting those people who are providing care of their well-being? Thank you.
All right, so I'll have two more questions and then we close off. Two on this side, please. Can you just give mic to these two questions on the left side? Yeah. Yeah, please, here. Yeah, two on this side.
I'm Dr. Archana from Udan, India. My question is that one of the potential solutions for this educational support is the community, type 1 diabetes community. And why is that not explored by all the organizations? I just wanted to give 1 minute of example that in Aurangabad, where I am, the government medical college did not have, with all the resources, could not provide education, but we have a team of 18 trained people living with type 1 diabetes who offer this support system, and now all the pediatric endocrinologists and the government medical college sends their people living with type 1 diabetes for our support and encouragement. So it's a very good two-way kind of a system which takes care of them.
Thank you. Next question here. Yeah.
And thank you, everyone, for your wonderful presentations. My name is Sana. I'm from Pakistan. So my question is, after listening to all of you, and maybe any one of you can answer this, is we hear a lot of challenges. Those challenges are systematic, those challenges are social, those challenges are financial, and so many more. And we also have been hearing the last 2 days that even when insulin is provided and test strips are provided, the HbA1cs are still on the higher side. I'll share one very small incident with you, a story that I know about. A child living very far away, 1.5 hours from the main city. The mother keeps the child high all night because she's afraid of nocturnal hypoglycemia. Another child I know about, when she has been into 3 DKAs in the last 1 year, and she's on our insulin support program, because whenever she has a fight with her siblings, she refuses to take insulin. So there are psychological problems, there are other issues as well. If I could ask you to pick one particular thing which, if you could provide in your countries, would actually move the needle the most, what would that be?
Thank you. I think you have enough questions. I don't know how you want to do it, but please be short, sharp, and to the point.
I think most of the questions are forgotten by me. I'll just start with the first
you can
question. What Professor Jean has asked regarding the quality of the care, That's what we should all aim at, We are always thinking of availability. That's one part of the story, but also we should live in the present and try to do the best of the things. And the support which we should have is a comprehensive support rather than the compromised support. We have to have everything, not one. 1 or 2 will not have the quality of life. If the education or of the support is very comprehensive, then we can do the better things. That's the only way out.
Dr. Babu?
Thank you so much. I think many of them are comments, a few questions. I agree with the comment. My comprehension of this is the problem of type 1 diabetes is not only medical issue. It involves many psychosocial issues. And when we start to understand and to work together with social workers, with association, we improve the quality of life. What is, I think it is more important. We have doing many in trying of medical management like insulin, glucose monitoring, but we feel that the level of control is not good. And when we try now, we are doing a study comparing children with we have benefit from diabetes camp and children who did not benefit, and we see that children we have gone to camp have better control and have better quality of life. And we think that psychosocial issue is the key solution for them to improve their glycemic control and quality of life.
Dr. Seklan, do you have any comments?
This disease is initial attending the hospital, but in Latin America, the reforce of the level primary care is very important now. The policies actual in Latin America going to the reforce the level primary and the create module about attention to diabetes type 1. I think that the mechanisms of the attend this group is reinforce the health primary level. The inequality of the insulin begin in these sectors, and if necessary, attend exceptional meeting.
Thank you. Roberta?
Thank you so much. So I'll start with the last speaker. If there was one thing I think would move the needle most, would be structured, and my emphasis is on structured self-management education, which is culturally sensitive and linguistically appropriate. For me, that would be the one thing. To Prof. Mbanya's question about complications, yes, my answer to that is supplies, 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 supplies. Because if you have the supplies, then you can do more frequent testing, you can do more frequent dosing, and you can sort of advise yourself or make the necessary behavioral changes as needed. I agree with the use of the type 1 diabetes community, and the key word in that is trained, because people who have lived experience must be trained. Otherwise, it is difficult for them to disengage their own experience from what another person, and so training is critical, but that is such, an amazing resource if you are able to train them, because there's nothing like somebody who has been there before you and is willing to hold your hand. Totally spot on. With reusing single-use insulin syringes, it has its own problems, from lipodystrophy, pain, and most important, changes in the PK/PD properties of the insulin that is being injected. I think that'll be all for me.
Okay,
thank you.
So I'll take a moderator's prerogative to ask a few questions. Senegal, at one point in time, you provided free insulin to all the people with diabetes. Is that program still on? And I'm not sure if that program is on. Are the children part of that program? Or the program has now ceased? Because I remember at some point in time, insulin was provided free to each and every person diagnosed with diabetes in Senegal. You see? So I'm not sure. In India, my question was, you've got huge amount of human resources. You are exporting human resources. You are a world's capital of medical tourism. Still, why is the public sector lagging behind so much? Is why that skill set is not passing on from the private to public sector, and why that partnership is not working to improve the quality of care for these children. And there are so many philanthropy organizations in India. So why is there nothing coming out of India itself to self-manage these children? You know, Peru, I think, I'm not sure if there are any donor programs there, but I think Peru has its own challenges. And in Ghana, in Africa, it is supposed to be the leader of the social health insurance. So within its social health insurance, has this been incorporated or not? Short answers, quick question, 2 minutes, we finish.
Okay, I think the question is the availability, accessibility of insulin without CDIC. This?
I'm talking about the government-led program whereby the government used to provide free insulin.
Yeah, I think that the insulin availability is a reality in Senegal. Even before CDIC, with the Senegal Association, we negotiate with the government, not free, but a cheaper.
Subsidized.
Yes,
Yeah.
really cheaper insulin, human insulin. Even the analog have been subsidized by half. The price is half less than normal price.
So can it not be extended to the children with type 1 diabetes?
It is for all person who need insulin in Senegal.
Okay, fine.
But with the program, you see even in the program, children in the program, 1/3 of them use analog by paying by themselves.
Okay.
Yes.
Dr. Reddy?
Yeah, the health system is very fragmented in our country. At one end, at the highest level, we are doing, the other end, we are not doing well. And there is a disparity in this. That's one of the reasons, maybe huge population we have, 1.3 billion. It's not a joke. And the second thing is, most of the people are concentrated only in the cities, not in the periphery. And though in the health system, we are just making some strides. Now the diabetes is included in the Ayushman Bharat Pradhan Mantri Yojana. But unfortunately, it is not looking into the juvenile diabetes. And there is also one more scheme, what is called the Rashtriya Bala Swastha Karikram, where it looks after 32 other diseases, they look after everything, right, for the improvement of the care of all the children they look. But unfortunately, that is not introduced there, and that process is going on. These are some of the reasons we are into that.
Yeah, you need a strong advocacy there.
Yes.
Yeah. All right, okay. Peru, you have any donor programs?
Peru have a general law of diabetes. In the last 2 years, implement for example, after 40 years, included in the list of the medicament analogs of insulin, glargina, degludec, after 40 years. But it's a product of the force of association of patients that impulsed the law, not included the medicament. Actually, currently, is it the process with general budget for the government, but it's necessary for our children and young with diabetes type 1.
Thank you. Ghana?
So thank you so much. So we do have human insulin available on our insurance. Unfortunately, what is available is premix. And the evidence, we know that for children, you want to use a basal bolus regime. So even if you are using human insulin, it must be a basal bolus that is not available. Number two, supplies. I cannot understand, we have engaged the National Health Insurance, that it is criminal to give somebody a potentially, let me say, a medication that can lead to death within minutes if they get it wrong, and not give them supplies to be able to check what is happening or to do their dosing. So our insurance will give you the insulin. Unfortunately, it is pre-mixed, it is human. You will not get supplies. You will not get needles. You will not get glucometer. You will not get strip. The other thing is what a facility can stop depends on how they are classified based on the National Health Insurance. So we have, unfortunately, still facilities who don't have doctors. In Ghana, it is doctors that are licensed to prescribe insulin. So if you are in a facility that is not licensed, sorry, you will not have insulin. It doesn't matter how far away you are.
Okay, and
Thank you.
one final question. Each one of you talked about analog insulin. So you have not been able to control your children with diabetes with human insulin. So how are you going to control them with analog insulin? So tomorrow donors decide we are going to give you analog. So instead of Land Rover, you are going to go in Mercedes-Benz. Are you going to be able to control the patients? So tomorrow all the donors say, okay, we are giving you, because each one of you mentioned analog.
Yes.
So you think analog is the answer, or is it the system change which is the answer?
To an extent, analog is also an answer.
Are you sure?
Yes.
Okay,
Because
let's not go into it. I think we'll discuss it.
Let me
later on.
issue a disclaimer.
Okay.
I talked about regime.
All right. So let's give them a very big hand and let's move over. Thank you.